Thanks, Rupert and Sarah, for the invitation, and thanks, Carlos, for giving me some slides for this presentation. You know, we worked together for several years working on blood biomarkers of ketamine response, like a decade ago, and I'd like to go over in this presentation some findings that you had at NIMH and some recent updates in this area. Basically, ketamine is a complex drug, you know, that targets several neurotransmitter systems, intracellular signaling cascades, mitochondrial function, oxidative stress. And by being so complex, it could be called like a multimodal approach for depression. And depression that ketamine tries to target is a very complex disease that it has atypical features, melancholic features, anxiety, comorbid symptoms. And in this case, we are matching a very complex drug that has several mechanisms of actions with several very complex disease. So the task to find biomarkers for this condition is very complicated. So we are trying to approach in a way that we can identify biomarkers that are related to clinical response in a sub-specific group of patients. Basically, in this case, we have to identify blood biomarkers and other biomarkers that could be related to response and remission, like predictors of response, baseline levels of biomarkers that cross-sectionally you have a clinical outcome later on, and surrogate outcomes, which is more sophisticated by having the biomarker measure more than once. So the clinical improvement would match with the changes in the biomarker. So this is my disclosure. I have a couple of clinical trials in depression and suicidal ideation with ketamine, and but no current study on biomarkers. So in terms of biological systems and biomarkers of response to ketamine, Carlos presented yesterday a wide range of findings related to improvement of depression associated with changes in connectivity, epigenetics, neurochemical, neuroplastic. So depression in this case has a wide range of findings related to you see the AMPA, throughput, and MDA. In this case, that was the first biological mechanism proposed that was presented here already, showing that by blocking the AMPA activation, you would abolish the rapid antidepressant effects of ketamine. And this would be related to the early effects of ketamine, and the sustained effects would be activation of neurotrophic effects through CREB, BDNF, and BCL2. That was early 2008, like several years ago. More recently, we had more findings supporting increased AMPA throughput and activation of AMPA receptors, mTOR, EF2, and BDNF. How this could be translated into like clinical new options for depression. mTOR is complicated because if you upregulate mTOR activity, you put the body at risk for cell proliferation in organs other than the brain. So mTOR is a key target in cancer research. So as a mechanistic approach is interesting, but when we think as mTOR as a potential therapeutic approach, is more limiting. The same for GSK. GSK inhibition has been associated with the effects of ketamine, but if you consider GSK inhibitors for depression, you are going to also find several side effects that are not expected in different organs. So also suppression of glutamate input to GABAergic neurons and synaptogenesis and dendritic remodeling. These are basically the main models, mostly done through preclinical studies, and which we have to think about how to translate this into our blood biomarkers in patients. So some of them we are not able to obtain, but most of them we were collecting time by time some biomarkers from preclinical studies and testing our patients for NIMH. So basically, in terms of the predictors, BMI was the first that came out. So obesity would be a factor to improve response to ketamine. But we have this question, you give more ketamine for those obese patients because it's per kilo. So the more kilos, the more ketamine you're gonna give to the patients. And family history of alcohol use disorder was another clinical predictor. Then another evaluation was the predictors. Once you improve depression after 1 day, what are the symptoms that were related to long-term improvement? So all the findings that we present here are based on a single IV dose and the improvement after 24 hours, predicting improvement after 14 days. The remission and response after 14 days was low, like 20 to 30%. So it's important to identify specific symptoms that would be related to improvement later on. Before starting on the blood biomarkers, these are also findings from the NIMH group at that time related to sleep ratio, MRS, low GLX glutamate ratio. Giacomo Salvadore did other paper on increased treatment ACC activity. And we confirmed that BMI was a strong predictor as well as family history. So moving along with the biomarkers, the blood biomarkers, we collect blood, plasma, serum, RNA, and we had a wide range of markers that we evaluated. This was one of the kynurenine pathway and antidepressant response to ketamine. Basically, we evaluate at baseline and after day 1 and day 3. So the main findings is that like the enzyme indolamide was lower after ketamine, which means that tryptophan would go to serotonin and melatonin, to the other side of this cascade that I'll show next. And the kynurenine basically would increase, you see like B, that would also activate the kynurenic acid. And this is the step related to neuroprotection. When you think about neurotoxicity, you would consider the quinolinic acid, which is the last one, D, that did not change over time. So it seems that ketamine activates this pathway, but related to astrocyte effects to block an MDA receptor. So it could be a kind of booster in terms of ketamine effects by also blocking an MDA receptor. This is basically the mechanism by which kynurenine would increase kynurenic acid in the astrocyte and activate, block an MDA and alpha-7 nicotinic receptor, which was also related to antidepressant effects of ketamine in early studies, which would also block quinolinic acid. So basically, this is an important finding that also by the other side could block oxidative stress, activate, impair mitochondrial function, and limit the production of quinolinic acid. So since we observed that the BMI was a strong predictor of ketamine antidepressant response, we perform evaluation of adipokines. Adipokines are basically regulate inflammation, neuroplasticity, insulin sensitivity, bone metabolism, and sympathetic outflow. So we evaluated adipokines at baseline to 30 minutes, day 1. Some of them we did at day 3 after the IV infusion in 80 patients. So the 3 adipokines we evaluate were adiponectin, resistin, and leptin. Adiponectin is kind of good guy, improves all the parameters. Resistin is the bad guy, and leptin is like 50-50. You see next the effects of each one. Basically, you see here adiponectin can improve insulin resistance, can decrease the sympathetic increase output and could have anti-inflammatory effects. It could improve plasticity. Leptin would improve insulin resistance and could decrease sympathetic tone, but wouldn't have positive effects in inflammation and plasticity. So leptin is the insulin, the enzyme that you see that has a key role in obesity. You remember that those animals, the rats, very obese, was related to leptin. Resistin would be like deleterious in several aspects related to insulin resistance, sympathetic flow, and would impair plasticity. So we're expecting to lower resistin after ketamine and induce positive effects in plasticity. Remembering that these are all blood markers, that some of them have the criticism, what would be the correlation with the CNS? Some of them we have evidence, but not for all. Basically, we see any change in adiponectin levels, but baseline adiponectin predicted the rapid antidepressant response of ketamine. So lower baseline adiponectin associated with higher superior antidepressant effect. Leptin increase over time at day 1, but there is no association between change in depression scores as well. And resistin lower after ketamine at day 1. And surprisingly, so far, no one can explain, and we didn't find any reasonable hypothesis to support why resistin lower in bipolar patients, but not MDD, which is very strong, like you see from baseline to day 1 in bipolars. There is a significant increase, but we don't have any clear explanation for this findings. Other peripheral marker we evaluate was SHANK3. Basically, SHANK3 regulates synapses and can activate an NMDA receptor. So we evaluate blood SHANK3, and SHANK in preclinical models have been associated with manic-like symptoms as well. So baseline SHANK was a strong predictor of antidepressant response to ketamine at day 1 and day 3. Higher baseline was associated with greater improvement of ketamine. So the NMDA receptor would be more active by having higher SHANK levels and would give more room for ketamine to induce antidepressant effect. But there is no change over time in SHANK3 levels, just the baseline levels predicting response later on. And this finding, the baseline peripheral SHANK3 was also associated with increased glucose metabolism in the hippocampus and amygdala post-ketamine infusion. Back to the bone, basically ketamine seems to be a good medication to treat osteoporosis in some cases, because this was suggested by Phil Gold. Phil Gold was our mentor at NIMH. He was in charge of the all metabolic panels and studies. And he suggests us to do these biomarkers, which are bone markers, RANK-L, and OPG. They are related to bone formation. And the findings we have is that all the good guys in terms of improved bone density were increased after ketamine. But there is no association between these markers and improvement of depression. So that's like a kind of incidental finding in terms of potential relevance in other conditions other than depression in this case. Disserine was also a response marker to ketamine. There is an association between baseline disserine and L-serine and antidepressant response to ketamine, with lower levels predicting a better response. So basically, disserine and L-serine are co-agonists of the NMDA receptor. So if you have lower levels, you have less active NMDA receptor. So that would help ketamine to make effect faster and more robustly. But did not change over time. You see here, there is a difference in the serine levels compared to comparing responders and non-responders, with responders having lower level, but the levels do not change over time. So ketamine did not directly affect, but it seems that the levels can account for the clinical response in depression. This was another study. We did a GWAS. We didn't have too much power in this study, kind of small sample size for GWAS. But the top candidate in this study was MCF2L2, that is basically focused on, has main effects on plasticity, cytoskeleton organization, and cell proliferation. So we talk a lot about plasticity. Plasticity is a very generic term, and when we discuss association with depression, we can find a wide range of potential concepts of plasticity, but in this case is related to cell proliferation. This is an overview of the findings in terms of improvement of depression at day 1, predicted by baseline biomarkers of response. So we have the biomarker, the baseline levels of each biomarker, and how were they correlated with improvement at day 1. So L-serine and D-serine seem to be good candidates, higher baseline related to better response, and SHANK3 the opposite, lower baseline related to better response. And we had some other candidates, ACTH, we're not able to explain well or even like explore more this pathway, the stress pathway. But ACTH, higher baseline ACTH seems to be related to better response to ketamine, which supports the HPA axis modulation of ketamine. When separate across different dimensions like the glutamate, inflammation, metabolic, and plasticity, we observe similar findings. Again, BDNF came out significant. Our first study with BDNF, we didn't see any change over time, but subsequent analysis, we observed increase in BDNF over time in association with clinical response. When we put together clinical and biological predictors of ketamine effects, L-serine and D-serine are the top ones, and then SHANK3. A little higher than BMI and family history of alcohol. Then you have adiponectin and other findings, but basically we have like Pearson 0.5 for L-serine at baseline. That could be help to stratify samples in the future. Basically, here we show different biomarkers related to change over time. It's a little complex, this figure, but you see like in red ACTH, that is like biomarker that has correlation with depressive change over time. And BDNF related to change in depression and change in the marker. So we observed that the same way patient improved depression, but BDNF went up. And that matches with recent literature. This is a meta-analysis comparing baseline levels of blood-based biomarkers in responders versus non-responders to ketamine. This is in present molecular psychiatry, and you can see that when you compare only baseline, you don't see any difference for any biomarker, and we select basically at studies that had at least 3 studies for specific biomarker. But when we observe like changes in responders and non-responders post-ketamine, we see a significant effect for BDNF for responders. So you don't see the same trend for non-responders. So it seems that after giving ketamine, you see an increase in BDNF levels related to clinical response in depression. Inflammatory markers in this meta-analysis did not show any difference by comparing to IL-6, TNF-alpha, IL-10, and IL-8. So conclusions, basically, BDNF seems to be a good candidate. Inflammatory markers at baseline predicting antidepressant response. Adipokines, plasticity, and MDA, and other targets. There is like methodology issues in terms of analyzing each biomarker. For example, BDNF, if you go back to the results, you see the levels at baseline, the mean, very heterogeneous. So each researcher uses a different kit from a different company with a different sensitivity, and you don't have like a clear result. So if you have BDNF between 100 and 1,000, this is within the normal range. So we are looking for biomarkers, blood biomarkers, that would be great, but we still didn't get to the point to have like a homogeneous way to analyze all the biomarkers and come up with some result that would allow us that's normal, that's abnormal, and all the researchers across the country or anyone doing ketamine-related research could use the same method exactly to come up with similar results. Thank you.
Any questions? Yes.
So beautiful talk. Given your data clinically, should we, and the cost of ketamine infusions, should we be getting L-serine, D-serine?
Very good question. This is like a preliminary data. I think that would deserve like a higher sample size, more patients. Seems promising, but at this point, nobody has replicated this, which would be timely. I've seen a couple of preclinical studies exploring a little bit these markers, but in practical terms, at this point, I would not recommend.
Another question?
I have one.
Oh, yes, sure, Sarah.
Thank you. I was wondering, when you look at responder and responder and biomarkers related to that, would be after a single infusion?
Yes, all the data I present here is after a single infusion. We didn't do at NIMH basically repeated infusions, at least when I left like 5 years ago. I'm not sure Carlos is doing now, but all 0.5 milligrams per kilo single infusion and follow up for 2 weeks, no more than 2 weeks.
Yeah, we have.
Have repeated now? Okay. Yeah.
Rodrigo, I have one question. I mean, you sort of broke it down by function. Did you break it down by cell type at all? Like D-serine is largely generated in the astroglia. You mentioned that as a thing. Have you looked at other? I saw S100 beta, it didn't look too big. How about like GFAP or anything?
We did several GFAP and several other neurotrophic factors. None came out significant. And we did all in plasma samples. We didn't collect like, we collect lymphocytes. No, we collect PAX gene like RNA, but no lymphocytes, no cells.
Okay, thank you. Thanks. Okay.